Hi everyone, my name is Christian Clare. I'm one of the spine surgeons at New Hampshire Orthopedic Center. I grew up on the seacoast of New Hampshire in Somersworth, and then I went to the University of New Hampshire for my undergrad, where I got a biochemistry degree. I then went down to Philadelphia, where I did medical school at Jefferson Medical College, and then went up to Dartmouth for my orthopedic residency, and then down to Charlotte, North Carolina. I was there for a year doing a spine surgery fellowship, so it's nice to be back home. I spend most of my time in Nashua, Londonderry offices. Currently living in Wyndham right now. So it's one of my first Zoom talks, so bear with me. I'll be talking about a few different topics today. These PowerPoints were all combined from maybe 10 or 12 other presentations, so there's a lot of information to cover. I'm not going to touch on all of it, but hopefully this is a good overview for you guys. I'm going to get started with the motion preserving cervical spine surgery. So my email is up on the screen right now. If you guys have any questions that you don't want to ask during the live session or anything you want to get in touch with me about, just send me an email. The more memorable the subject is, the more likely I'll be to respond. So I have no relevant financial disclosures for this discussion. So I want to get started with a little bit of spine terminology, and this will help us for this talk, but also the other two talks that I'm giving. So the first thing is spondylosis. So spondylosis I really just associate with arthritis. This is just wear and tear, it's degeneration. This can happen in the discs or it can happen in the back of the spine in the facet joints. Spondylolysis, that's when there's an actual defect in the pars. And the pars are the part of the bone that connects the superior articular process to the inferior articular process. So when there's a defect there, and that can be a fracture, it can be congenital, it can be traumatic, it can be from cancer. Anytime there's a defect in the pars, that's called spondylolysis. Stenosis, this is when the spinal canal is narrow. And usually what I tell patients is, you have nerve roots, normally they're free floating like spaghetti. Stenosis is when the canal gets smaller and bunches up those nerve roots together. It can also be the spinal cord if you're in the cervical or the thoracic spine. One of my favorite words, spondylolisthesis. I used to practice that in the shower in medical school. This basically just means that one vertebrae has shifted forward on the other. This is most common at L4-5, it's degenerative, or at L5-S1 if it's in isthmic spondylolisthesis. Spondyloptosis, that's when one vertebrae completely shifts forward on the other. So it's a complete spondylolisthesis. And then we have radiculopathy, which is when patients have pain, burning numbness. They have symptoms that are caused from a nerve root being compressed. Then we have myelopathy, which is a issue with the spinal cord being compressed, and that can lead to funny symptoms like issues with balance, issues with clumsiness in the hands, dropping things. We'll touch on a little bit more later. Talking about the anatomy of the cervical spine, we have the discs between the vertebral bodies, and those are the shock absorbers. Over time, those shock absorbers start to wear out, they dehydrate, they shrink. When things shrink, the foramen or the nerve tunnels start to get smaller as well, and that can lead to pinching of the nerve roots, which is demonstrated on this picture on the right. The uncovertebral joint is highlighted in blue. You can see how close that is to the nerve foramen. So you can imagine if you start to get arthritis there and you get bone spurs, that those can encroach on the foramen and they can pinch the nerve root. We'll talk about the lumbar spine a little bit later on, but in the cervical spine, the nerve roots exit underneath the pedicles. So between the C5 and the C6 vertebrae, the C6 nerve exits. So any issues at the C5, C6 level will affect the C6 nerve root. And this is important because there's a mismatch between the nerve roots and the vertebral bodies, because there are 7 cervical vertebrae and there are 8 cervical nerve roots. So there's a mismatch until you get down to T1, and then things change. The nerve root starts to exit underneath its corresponding pedicle versus above. So cervical radiculopathy is when the nerve root compression causes pain. It can also cause symptoms like burning, tingling, numbness, weakness. loss of reflexes. And cervical radiculopathy can be caused by stenosis in the foramen or a posterior lateral disc herniation. In the cervical spine, either one of those will affect the exiting nerve root. So at C5-6, that would affect the C6 nerve root, whether that was stenosis in the foramen or a disc herniation. So first step is physical exam. You want to know where the pain is going to. You want to know what symptoms they've been having. So a patient who has a C5 radiculopathy will have weakness in their deltoids, their biceps, and it's the biceps reflex that we check. C6 is more brachioradialis wrist extension, brachioradialis reflex. The way I remember C6 is like a six shooter. So C6 usually goes to the first two fingers. C7 usually goes to the middle, and that's the triceps. And then C8 usually goes to the ulnar two digits. So you can imagine that a C8 radiculopathy gets confused a lot of times for ulnar nerve issues, which can be caused in the cubital tunnel. And on the same page, C6 can often be confused for carpal tunnel syndrome, which is compression in the median nerve. Workup, let's start with x-rays. X-rays help us rule out the scary things, so they show us fractures, dislocations, they can show us shifting of the vertebrae, they can show us the overall alignment. This is a good baseline, and whenever we're operating, we're always changing the alignment, we're changing the anatomy, so we want to know what the baseline is. We want to know where the patient's at without surgery, where they're at to start with. If they continue to have symptoms, then we move on to more advanced imaging, which is a CAT scan, MRI, and this shows us things in 3 dimensions. I always tell patients that x-rays are a little bit tricky sometimes in the cervical spine because they're 2-dimensional images of something that's 3-dimensional. So it's hard to see all the fine details. So we get advanced imaging to see that. CAT scan's not the most common. I usually use this only for preoperative planning. MRI is really kind of the most common advanced imaging to get because this will show us all the soft tissues. This does not use radiation, uses a magnet, and this shows us things like the spinal cord, the nerve roots, the disc, the spinal fluid. This helps us evaluate the patient to figure out exactly where the neural compression is coming from and helps us plan surgically. This is an example of a couple of axial CT scans. These are showing foramen stenosis on the right side. You see this where I'm highlighting. And then this is an MRI of a cervical disc herniation at 2, 3, 4, at 5, 6. So this is 5, 6 on the left side, and these are both T2 weighted films, sagittal on the left and axial on the right. And again, a C5-6 nerve root, or excuse me, a C5-6 disc herniation on the left side is going to affect the C6 nerve root. So we'd expect 6 shooter. We'd expect symptoms in those 2 digits. And again, the nerves don't always read the books, so it can vary. Sometimes it doesn't go all the way to the fingers. Sometimes it includes additional fingers, which makes things a little bit trickier when you're evaluating patients. So physical exam, we talked a little bit about reflexes, motor function. One special test is the Sperling test, which is demonstrated in this picture. And this is when you actually load and you try to compress the foramen to try to elicit some symptoms which the patient's experiencing. So most patients, when they have pain, they have a pain cycle. Something happens and they have a sudden increase in pain. They take it easy for a few days. They take some Advil. They put some ice on it, and it starts to feel better. They start to go out. They do more. It starts to hurt again, and it's a cycle that you have to break. You have to get them up over the hump, feeling better, so they're back down to their baseline. We do that with non-operative management at first, and almost 75% of patients will get better, if not more. And we always start with things like anti-inflammatories. They come in non-steroidals or steroidals, physical therapy, chiropractic work, narcotics. I try to avoid narcotics because studies have shown that patients who undergo spine surgery do worse with surgery if they've been on preoperative narcotics. So I always try to avoid narcotics unless the patient is having extreme pain. Epidural steroid injections can be very helpful. These can be both diagnostic and therapeutic. So therapeutic in the sense that they take away the patient's pain, they make them feel better, but diagnostic in the sense that they also tell us that the spine or the nerve roots are the root cause of the problem. Operative management, the gold standard for the past, I don't even know how many years, would be the anterior cervical decompression and fusion, or the ACDF. ACDF is a procedure where you go in through the front of the neck, you make an incision about 2.5 inches long. Usually you try to hide it in a skin crease. And this is actually a fusion procedure where you're putting in bone graft, you're trying to get the bones to fuse. This is done usually with a plate and screws. More kind of cutting edge or new techniques include motion preserving surgery, which is the anterior cervical discectomy and arthroplasty, or a posterior laminar foraminotomy. And those are the two things we're going to touch on in this presentation. And again, these are for radiculopathy. We're going to talk about myelopathy in a little bit. So why fuse? Why do motion preserving? So with fusion, you're putting a plate, you're putting screws. That plate is right up against the esophagus. That can lead to hardware complications. You're putting in a spacer. Usually that's either plastic or titanium, or allograft, like a cadaver bone graft. Most of these are harder than patient's own bone. So if you put in a very hard implant in a patient who has very soft bone, that can lead to settling, where the graft will actually push through the vertebral body, and that can cause things to settle, which is the exact opposite of what you want to do, because we want to increase the space between the vertebral bodies to increase the space in that foramen. In the past, autograft was used a lot, and patients really hated this. We used to take autograft from patients' iliac crests. And I remember as a resident rounding, you could tell the patients who had an autograft procedure because their neck didn't hurt them, their hips did, which I always thought was a little bit crazy, that, we were causing them more pain than they really needed, or we're causing a different type of pain, and sometimes that would linger, and sometimes they would have postoperative complications where they have bleeding or nerve injuries. So autograft really kind of fell out of favor, and we typically use allograft at this point. If a patient has significant neck pain, that's not going to get better with a motion preserving surgery. So significant neck pain usually is a result of arthritis, and if you have arthritis in a shoulder or a hip or a knee, we can just replace that joint. We can't do a spine replacement. There's not really a good alternative. So in the spine, we reduce the motion by fusing. So if a patient has significant neck pain, usually they're going to undergo a fusion type procedure. Whenever you fuse two bones together, the ones above, the ones below work overtime. So you get the risk of adjacent segment degeneration, which is when they wear out. And the risk of those patients who you do a fusion on, the levels above or the levels below, becoming symptomatic is about 3% per year. Versus motion preserving, where now you have this patient who continues to move, the ones above, the ones below aren't seeing more stress, but the level that's moving can continue to wear out and become arthritic. And that happens a lot less. That's about 5% at 10 years. So the first thing we'll talk about is a laminar foraminotomy, and this was first done back in the 40s. This is a posterior approach. There are complications associated with the posterior approach, but this is usually used for 1 or 2 level unilateral symptoms, usually 1 dermatome, maybe 2 dermatomes. Going through the back of the neck has its own risks. The muscles in the back of the neck are very thick. There's increased pain. There's a lot of blood vessels in the muscle in the back of the neck, so there's increased bleeding. Blood loss is usually a lot more than going in through the front. The back of the neck is a very sweaty place, especially if you're using a cervical collar, whether that be soft or hard. So it's tend to dehiss or get infected a lot more than an anterior cervical fusion. So this is an example of when a cervical laminar foraminotomy may be useful. So this is an example of foraminal stenosis right here on the left, circled in red. You can see that the foramen here, and this is the right side, is a lot tighter than on the left side. And these are other images demonstrating the same thing, sagittals and axial images. So the procedure, I put pins into the patient's head to suspend their head in place, and then make an incision on the back of the neck. I use a needle and x-ray to plan my incision before. And after we expose the nuchal ligament in the back, we move the muscle out of the way to expose the facet joints. Once we do that, we use a high-speed burr, you can see on the right side, to open up the space to make more room for that nerve root that was being pinched. Again, that nerve root was being pinched in the tunnel as it exited, so you want to remove the extra bone. So on this image, you'd want to remove basically all of this to make sure that the nerve root was free and mobile at the end of the case. Postoperatively, I usually just use a soft cervical collar, and this is really just for comfort. I tell patients that they can wean out of it once they start feeling better. The first 2 weeks, patients really aren't feeling like doing a whole lot. They just do light activity. Once I see them at 2 weeks, that's when I start outpatient PT. And really, I want them to work on active range of motion, postural strengthening, increasing their cardiovascular endurance. Usually I get them back to work or sports if they're doing well at their 6-week visit. Cervical disc arthroplasty. This was first invented as a way to try to combat the adjacent segment degeneration, which is most commonly quoted at about 3% per year, based on one of Hillebrand's studies. Studies have looked at fusion versus arthroplasty, and these have been all over the map, and it depends who is performing the study. Is it the companies who make the cervical disc arthroplasty, the prostheses? Is it companies who make the fusion prosthetics? Is it an independent company? So really they're kind of all over the map. Some have shown that they have no difference and they're equivalent. Some have shown that the cervical disc arthroplasty has a decreased incidence of adjacent segment degeneration. Another issue with fusion is pseudoarthrosis. So this is when you're trying to get the bone to fuse and it doesn't. And this can become painful because patients continue to have neck pain because that degenerative segment continues to move. And again, motion is painful, so they still have neck pain afterwards. And this can require going into the back to do a revision procedure. So when to do a cervical disc arthroplasty? Usually this is for patients who have either myelopathy or radiculopathy that have failed conservative treatment. They either have central stenosis from a disc herniation, they have foraminal stenosis from a disc herniation, or an osteophyte, a bone spur putting pressure on the nerve as it exits through the foramen. Tend to avoid this in patients who have osteoporosis. Osteoporosis is increased risk for settling of the implant because we're relying on the hard bone to provide a surface for the arthroplasty to kind of adhere or grow into. If patients have degeneration at the levels above and levels below, we may tend to avoid doing an arthroplasty because those levels may continue to wear out and they may need additional surgery. Or if the patient has disc height loss. When the patient has disc height loss, the way to increase the foramen is by making the disc bigger or making that space bigger. And if you try to do that with a cervical disc arthroplasty, if you increase the space in the front, it decreases the space in the back where the facet joint is, and that can actually lead to pain, something called overstuffing. So we always try to avoid doing this procedure in patients who have a lot of disc collapse, because when you recreate that disc height to a more anatomic level, they are going to have neck pain, even if they didn't have neck pain before, because you're putting more pressure on that facet joint. So these are a couple images of a cervical disc arthroplasty all the way on the left. This is a schematic of the one that I typically use. This is the Mobi-C. On the middle image, this is an x-ray or a fluoro shot of a patient bending their neck backwards and forwards. This, you can see a 2-level Mobi-C. That's the only implant that's indicated for 2 levels. And you can see how much motion really occurs at those, the arthroplasty. Other implants only have a 1 level indication. So these are typically done in what's called a hybrid construct, where you do an arthroplasty at 1 level and a fusion at the other. That's one of the benefits of the Mobi-C implant, is that it's actually indicated for 2 levels. This is an intraoperative film showing the cervical disc arthroplasty implant. And again, because you're allowing continued motion, positioning is very important in these. So you really want to make sure that they're midline on the AP view. And then on lateral, you want to make sure that they're right within the concavity on the superior end plate, and then right flush on the inferior end plate. So this is basically a perfect intraoperative image. There are obviously complications that go along with any surgical procedure, and with the cervical disc arthroplasty, one of those complications is things continue to move, things continue to wear out. And if that happens, it can put pressure on the spinal cord, it can put pressure on the nerve roots, that can lead to a return of their symptoms. If that happens, you have to go in, you have to take the implant out, and then you put in a spacer, you put in bone graft, and you get those bones to fuse. You do an anterior cervical discectomy infusion. So going through the front of the neck has other complications that are, it's a trade-off. You going through the front, you going through the back, each one has their own set of complications that you have to deal with. So the recurrent laryngeal nerve goes down the neck between the trachea and the esophagus, and this can be injured. If that happens, it can lead to hoarseness, difficulty swallowing. This really comes into play when patients have had multiple surgeries. If you've had multiple surgeries, you have an increased risk of getting a nerve injury. And we always send these patients to ear, nose, and throat before, so we can make sure that the vocal folds are working. Because the worst thing would be if they've had a left-sided surgery with an injury and that left vocal fold stops working. If you go on the right side and ding the nerve, now they don't have any vocal folds working and they're not going to be able to breathe. Hypoglossal nerve injury, this is more common with higher levels in the cervical spine. The vertebral artery, again, this is rare, but this can be fatal, or this can cause a stroke. The most common complication with anterior cervical spine surgery is dysphagia. This occurs more often in patients who are older. The more levels you do, and the higher the levels. So if you're working up at C3-4, or you're doing C3 down to C7, like an 80-year-old, these patients are almost always going to have some sort of pain or difficulty swallowing postoperatively. And again, this can range from having a sore throat to needing a feeding tube. So this can be pretty significant. The sympathetic chain lays on the longus coli, which is in the anterior aspect of the cervical spine. Injury to this can lead to Horner syndrome, which is myocystosis, anhidrosis, and ophthalmosis. So we'll switch gears a little bit and talk about myelopathy. Myelopathy is just a disease of the spinal cord. This is when there's canal compression. This is when the spinal cord's being pinched. It leads to really funny symptoms like difficulties with balance. Patients wake up in the middle of the night to go to the bathroom. They have to hold onto the wall, otherwise they're going to fall. They notice that all of a sudden they need a cane, they need a walker, they're having clumsiness in their hands, their coffee mug will drop out of their hands, they can't hold a fork, they can't hold a spoon, they notice changes in handwriting, button zippers, doorknobs, keys, jar lids, all these things are very difficult for them. This schematic of the cervical spine and all the different areas where compression can happen from. So the ligamentum flavum in the posterior aspect of the neck, this can infold. You can get disc osteophyte complexes, you can get disc bulging, disc herniations. All these things can put pressure on the spinal cord. You can have abscesses, you can get ossification of the posterior longitudinal ligament. You can even have hypermobility. So one thing is when you get a MRI and everything looks nice and normal, you look at the cross sections and there's plenty of space for the spinal cord, and they're myelopathic. You're wondering, what's causing that? And then you get flexion extension films and you see that their vertebrae are moving. Basically, every time they bend their neck, they're banging their cervical spine, banging the spinal cord against the vertebral bodies, and that's what's leading to their symptoms. So on the left is an example of OPLL, or ossification of the posterior longitudinal ligament. And you can see how that thickens the posterior aspect of the vertebral body, decreasing the central canal. On the right side, you can see that there's some change in the alignment. It goes from the normal lordosis in the bottom to actually kyphosis up top. And at C4-5, you see a little bit of cord single change, which the arrow is pointing to. And then C5-6, you can see some disc bulging. It's probably a disc osteophyte complex, and some infolding of the ligament flavum, and that's pinching the spinal cord at C5-6. So again, these are the symptoms. We touched on those. I always draw this picture out for patients in the clinic when they come to see me in the office. Myelopathy progresses in a gradual, stepwise manner. So the natural progression is to make steps down. So patients are doing well, then all of a sudden they notice that they're falling when they walk at night, and that's a step down. And then they do well for a while, and then they notice they need a cane, and that's a step down. And I always tell patients, I can't tell how long there's going to be before there's a step. It could be 3 months, it could be 3 years, it could never go down the step. But that's the natural progression, is to continue to deteriorate. And we do surgery not to get them back, dancing at the club on a Friday night. We do surgery to prevent them from going down any more stairs. And that's a very difficult conversation to have. And I've spent a lot of time with patients talking about that. And even when they accept that, or when they understand that in the office, when you see them postoperatively, they're always still fixated on not having resolution of their symptoms. You have to remind them that, listen, we weren't doing this to make you 100% better. We're doing this to prevent you from ending up in a wheelchair, or not being able to feed yourself, or not being able to use your arms. So it does become a difficult conversation sometimes, because it's not one of those surgeries where you do and you feel warm and fuzzy after because they come in and they thank you. Usually it's a long kind of process where they recover, and they might gradually regain some function, but usually patients don't get better. Usually they stay the same. So in physical exam, you want to watch them walk, use their hands. You check reflexes. Patients who are myelopathic are hyperreflexic. They have a positive Hoffman's, which is when you flick the DIP of the middle finger. If it's positive, thumb will flex. You look for clonus, check the Vinci sign, and one other sign is the Lermite sign, which is when you have the patient touch their chin to their chest, and they get an electric shock that goes up and down their spine. So non-operative management, not really a whole lot of place for this. If I have a patient who absolutely does not want surgery, then I have that discussion. I talk with them. I say, this is natural progression. Things are going to get worse. I don't know how long it's going to take, but if you absolutely do not want surgery, we'll continue to watch you. We can send you physical therapy. We can work on balance. We can work on coordination training. You can try anti-inflammatories. You can try injections, but really, all these things aren't increasing the size of the spinal canal, which is the issue. The spinal canal is decreased, and that leads to pinching on the spinal cord, which leads to the symptoms. So the only way to increase the spinal canal is with surgery. So all these things really don't have a huge role. These are only really not options, but these are things I offer patients who are absolutely opposed to surgery, and they haven't really accepted the fact that this may be something that they need. In terms of surgery, ACDF, the fusion procedure, this is when there's that kyphotic deformity. So when the head is forward, the only way to get the head straight is by going in through the front, by putting in that graft to open up that disc space to correct that angulation. You can do this with a disc arthroplasty. Again, disc arthroplasty, we're not trying to increase the size we're just getting out the soft disc herniation. So this can be done at 1 or 2 levels if they have a big disc herniation that's putting pressure on the spinal cord. The other 2 options are going through the back of the neck. So this can be a laminoplasty, which is motion preserving, or laminectomy and fusion. Both of these are indicated when there's multiple levels that are involved. I usually use 3 or more levels as an indication for going through the back of the neck. The more levels you do in the front, the harder the surgery becomes, because you're trying to go up and down 3 levels to put a plate and put cages and screws. And that becomes difficult doing through a very small incision. So usually at 3 or more levels, I start thinking more about going through the back of the neck. And again, doing motion preserving versus a fusion, I pay real close attention to how much neck pain they're having. Because when you go in through the back of the neck, they're going to have a ton of pain afterwards. So you want to make sure that if they have it before, that you're actually treating it and performing a fusion. So surgery through the back of the neck relies on having a normal alignment. So if they have kyphosis, which is shown on the right side, the neck is bent forward and the spinal cord bowstrings over it. So even if you take pressure off at the back, the spinal cord's not going to drift. It's going to stay bowstringed over the front, and they're going to not have any change in their symptoms. So it's important to get x-rays before surgery to make sure they have the correct alignment for what procedure you're doing. Sometimes you have to go in through the front and the back, and that's obviously a much more invasive surgery. So the first motion preserving surgery we'll talk about is a laminoplasty. And this is very useful when patients have multiple levels that are involved and you want to maintain motion. So this is neutral posture, or they still have their lordosis. Again, this avoids the complications of fusion, pseudoarthrosis, or the bones not fusing, and use this a lot in patients who have a high risk of having a pseudoarthrosis. So patients who are diabetic or smokers, their bone's not really going to heal anyways, so why try to make it heal in the first place? Just perform the laminoplasty. They can continue to move their neck, you take the pressure off the spinal cord, and hopefully prevent their symptoms from progressing. Again, anytime you're going posterior in the cervical spine, you will make sure there's not kyphosis, because that's not going to alleviate their symptoms. Their spinal cord is still going to be draped over the vertebral bodies. It's not going to improve. The cord can't drift back. And then patients who have severe neck pain as part of their chief complaint, they're not going to get better with the laminoplasty, because their worn out facets are going to continue to bother them, and they're going to be upset with you. This is a schematic of what we do in the operating room. So working from left to right, on the left, we use a high-speed burr. Kind of looks like a really thin Dremel tool. It's a 3mm matchstick. And we pick the side that's most symptomatic. So if they have most of their symptoms on the right side, I start on the right side. If they have most of the symptoms on the left, start on the left. So the side we start on is called the cutting side, and we use the burr to completely cut the lamina at multiple levels, and we go through both cortices. On the other side, we use the high-speed burr to just cut through the dorsal cortex. And that allows us to hinge or cause a green stick fracture of the lamina. And we don't completely detach the lamina like we do in a laminectomy. Basically, just we crack it. And then after we crack it, we secure it in place with a plate and screws. Again, this plate isn't going into the facet joints. It's not trying to get a fusion. We're not disrupting the facets. This plate is just going in between the lamina and then the area where you just cut. So C7, C6, C5, this is all the middle part of the spine towards the spinous process. And then we have a plate with the screw holding into the lamina. And then the facet joints would be out here. Again, these haven't been exposed, so they're not going to have pain in there afterwards. They're not going to get degeneration. They're not going to get fusion. And then the plate attaches just medial to that. So postoperatively, usually I use a collar for 2 weeks. Again, this is not a fusion procedure. You use it in smokers, use it in diabetics. You don't need to immobilize the spine. You want them to be able to move it, but also you want the wound in the back of the neck to heal, you want them to be comfortable. And again, when you go through the back, this is associated with a lot of the pain. It's more muscular pain. Usually I use anti-inflammatories because I'm not fusing, and then also muscle relaxers because the muscles get extremely irritated from the amount of retraction that they undergo. Patients usually spend 2 to 3 nights in the hospital and go home after that. I see them back at 2 weeks. We get a wound check. The main things I want them to avoid until they've healed are cervical loading activities or overhead arm resistance. I want them to increase their walking endurance those first 2 to 6 weeks. At 6 weeks, as long as everything's healed up and they're doing well, then we increase their activity, we increase their range of motion, we start working on some upper extremity resistance. So that's all I have for this talk. I will see you shortly for the next. Again, if you have any questions, any concerns, don't hesitate to send a email, or if you want, you can ask during the live session at the end of these presentations. Thank you.